Hello and welcome to my channel. Today's video discussion is going to be talking about my experiences at the South Carolina Hospice and Palliative Care Conference at the Columbia Museum of Art in Columbia, South Carolina. And if you're new to this channel, welcome. Thank you so much for taking the time to visit. My name is Peter Abraham. I'm a second career registered nurse focused in the areas of advanced illnesses, specifically those that would qualify for either palliative care or hospice care. Those are two very distinct types of services that are often confused, sadly, even among healthcare professionals. I'm also a certified end-of-life doula and a health and life navigation specialist at Compassion Crossing LLC that provides on-site services in Madison County, Kentucky, the 7 immediate surrounding counties, as well as being available globally for consulting purposes. And in this channel, we have discussions for my fellow hospice nurses, my fellow palliative care providers. I shouldn't say nurses, because this really impacts for hospice, for palliative care, for individuals, families, caregivers who are interested in these topics, as well as my fellow end-of-life professionals, most of whom are end-of-life doulas. And if these videos and topics are of interest to you, please consider subscribing, hitting the bell notification below. That really helps small channels like mine grow. And obviously, if you like the video, like it. You don't have to. So before I go on to the topic for today's video, which, by the way, is not just for those who are in hospice, those who are palliative care. But by the way, if you're an end-of-life doula, this conference would have been a fit for you. This conference would have been a fit for you. Before I go there, I want to ask you, what are you grateful for? I strongly believe in building resilience. The word resilience means the ability to snap back. Not necessarily instantaneously, but we have a lot going on. We have a lot going on. Oh my word, we're almost in April, so for 3 months, I've been seeing our financial portfolio go down significantly. We're doing okay financially, but it's like all this stuff could be really downing if that's your focus and you're not looking at what am I thankful for? What am I grateful for? So for me, I'm so thankful to God, and here I drove 7.5 hours straight on Thursday, the 26th. I left Berea, Kentucky at 7:30 a.m. To get to Chestnut Cottage Inn on Hampton Street in Columbia, South Carolina. I stayed my first time at a bed and breakfast, but I stayed there. It was a 7.5 hour drive. I almost was in a high risk situation on right as I was approaching exit 108B in Columbia. GPS was going to alert me too soon. Thankfully, visually, thank God, I looked over and I saw, ooh, I need to be over the 2 or 3 more lanes in a 4-lane highway that's very congested at the time. But I'm grateful for that. I'm grateful that, I was leaving the conference shortly, not immediately after my presentation. I answered questions and answers from people. I mingled a little bit, but I was leaving shortly after that so I could start driving to Hendersonville, North Carolina, where I was going to stay overnight before coming home Saturday. But like Dr. Ben Thompson, who invited me, these were going to be handed out at the end, but got the book, That Good Night from Sunita Puri, Life and Medicine in the 11th Hour. Did not get to start reading this yet, but had the opportunity to get this book. And I'm so grateful that my presentation, which was called Beyond the Flip, now if you follow this channel, on Monday, March 30th, this is filled in advance. So today is Sunday, March 29th. So tomorrow, you're going to get this on Wednesday, April 1st is when I'm planning to publish this video. But on my presentation for Friday, sorry if I'm losing track of time, my presentation was called Beyond the Flip, and I put that on the video, my YouTube channel, so that you'll see it March 30th, along with a very short take. I didn't read word for word. I didn't even read a lot from the case study, the sepsis case study. But Beyond the Flip was a twist of quick flips. So most hospice agencies, and when I talked to Dr. Ben Thompson, he's a regional medical director overseeing 90 hospice agencies for 90, do you say agencies, providers? But 90 of Gentiva's agencies, 90. And he confirmed that they use this. They use this. This is the quick one. This is my guide from April 2018. And it gives you a number of different diseases. And if the person has that disease, and you can go through the check boxes for the local coverage determinants, LCDs, they are eligible for hospice. They may live 6 months or less. They may live longer, but they're eligible for hospice. The catch is, and that was part of my presentation, the caveat, because my presentation is based on my book, Mastering Hospice Eligibility. And I want my clinicians out there that are doing admissions to look beyond the local coverage determinants. Don't throw them away if they exist. But the problem is that not every disease process like sepsis or a hip fracture or a femur fracture has a entry in here. There's nothing. What if they're a septic shock? Nothing. And it's not that you cannot admit them if you use this and use clinical judgment, but a lot of the, how to phrase, and I know we're going into this discussion as in part, I mentioned gratitude, but we're actually getting into the discussion, so bear with me. But the caveat for hospice, especially hospice, we have a nursing shortage nationwide. It gets worse every year. So I started hospice in 2018. We're in 2026 now. It is worse. So what's happening now is you have nurses that are in the hospital, they're getting sick of the hospital setting. Hospital nursing is the hardest, or among the hardest types of nursing, because no one who gets into the hospital, not to saying people who are in hospice want to be in hospice, but they're healthy. They have an acute event. They're in the hospital. Their attitudes are probably not the best. So hospital nurses, and I was one from February of 2017 to April of 2018. I did not take a vacation or break when I switched over to hospice as a rural hospice nurse. But you get spit upon. I got spit upon. You get kicked at. You get punched. You get food thrown at you. It is beyond difficult. And then the caseloads that are unrealistic. So you'll have nurses leave the ICU, I left cardiology, the ER, and so forth, and they'll go into other fields, telehealth, home health, hospice. And same way with long-term care. Long-term care is a mixed bag. Long-term care, and I took a break. I worked at a Care Hospice of York when they were owned by Golden Living, which is a long-term care community. I left there, went to Manor Care Kingston Court. They went through a name change because they were bought by Genesis, so this is called Kingston Court of York. But I went to work there naively thinking that COVID was going to stay over in China, maybe in Europe. Surprise, it came to the US, and we had close to 100% recovery rate because our first director of nursing tore up literally blows my mind, unscientific CDC guidelines. Former President Biden, CDC, was giving unscientific guidelines to the nursing homes, and literally, I'm being very transparent with you, I strongly believe they wanted people to die because the advice was that unscientific. It's like I was so grateful that our medical director was like, "Are you kidding me?" But anyway, I worked there. Then I went back to. We're going to get to the conference in a moment, so bear with me. But I went back to a Care. Now they're owned by Medicis. And what's happening with this, the shortage and everything else, is the training isn't always there. The training isn't always there. Just yesterday, March 28th. Keep in mind, I'm filming this on Sunday, March 29th. 9th. Saturday, March 28th, I'm catching up. I didn't bring my laptop with me when I went to this trip, because I'm like, what if I got into it? I was like the realistic person. Like, what if something happens to me and I don't ever get back? So I did planning with my wife if something were to happen to me on this long drive back and forth, so that nothing would, like, she wouldn't be in a panic or a mess if either A, I was stuck out there, or B, there was a fatality along the way. The drivers, by the way, along this, oh my. But here, there was a hospice nurse saying that he or she, I forget because it was anonymous, said that they've been a hospice nurse for 1 year. And there were so many different things that this person was never trained on. And this is happening nationwide. That's part of why I wrote 21 books. And to be very technical, the 21st book is to encourage people, both nursing students and bedside nurses and other types of nurses, come over to hospice, come over to hospice. So 20 books are the technicals. 20 books are the technicals. This is looking at hospice eligibility. I have, and I left it on my bookshelf, but I have compliance driven, tongue tied, on my word, or benefit of the standing desk if I can find it quick enough. And it is not sticking out here quick enough. Don't want to take too much of your time, but oh, I think I packed it and I have to unpack it. But my compliance documentation book, which is my #1 bestseller, is it compliance based eligibility driven hospice documentation for nurses. Sorry, short-term memory is like a butterfly. So I have that. I have clinical pharmacology. Hospice. How to phrase, pharmacology is different when it comes to somebody who's dying because of kidney function. I have a pathophysiology book. I have a book on what constitutes a complete hospice visit. So if you're a case manager, or even if you're doing this PRN, what should a visit look like from beginning to end until you sign out of that visit? What should that look like? The art of hospice visit planning. How do we plan? How many visits? Routine, we're talking about routine care. How do we plan for this? And yes, you can plan PRN visits in advance. Time management for hospicers. So part of the reason I wrote 20 books out of the 21 is because the training is not always there. The training is not always there. And so here, if you don't have a hospice nurse that's comfortable going outside the checkbox mentality that this has, because this does not give any guidance on how to interview. This has a whole chapter on interviewing. You don't get guidance. You may not ask the right questions. You might just go on clinicals and so on. So anyway, I don't want to spend too much time there. I want to dive into this part here. I was so glad. And I want to just preface this, and I appreciate your time. I am autistic. Didn't find that out until I was in my 60s. I'm high functioning, which I'm not Rain Man, but this is how, like, when I talk to others who are high functional autistics, they're like, Peter, that's why you were able to write that many books in such a short time. And that's why you're able, like I still remember, I know I'm going on rabbit trails, I still remember that when I worked in IT, I had to learn the Pascal programming language, learn the cash register binary language. I don't know if it was binary or hex, but I had to learn the cash register language. This goes back years. And I had to, I ended up writing from scratch because it would have been a mess to patches, like sewing and creating patches on holes. But the retail store was doing this frequent, like if you bought so much of their grocery products before a certain part coming up to Thanksgiving, you'd get so much of a pound turkey based on the volume. And it was way off. And I ended up having to learn the Pascal language, the cash register language, and write the program. I had to do this all in 6 weeks, doing everything from scratch. How could you do that? Well, I was autism high function. It's like a superpower. And I'm introverted, so Myers-Briggs INFJ for those who like Myers-Briggs. But I have panic attacks. Thankfully, you have not seen any. They're not pretty. They're not something I am ever proud of. It's very shameful for me when I have them. And I was sharing with Dr. Ben Thompson, who invited me, this was hard for me to have the courage and the bravery to move forward because I grew up in a very small town. The population was 3,000 people. 3,000. 3,000. And here in one of the reasons we moved to Berea, Kentucky, and I don't know the population in Berea, but it's small. It's small. I think it's under 10,000. It might be 5. Not sure the exact numbers. I think Richmond might be 20. But I'm only used to small. I'm a rural hospice person, drive up to an hour to get to a patient. But so here, going to a big city, when I looked this up on Google Earth, and I said yes before I even looked, and I'm glad I said yes, by the way. But I got to a point where I was scared out of my mind. Could I do this? And at first, my wife is, we'll go together and she'll drive. And yes, to a degree, some of you might say you're being a baby, Peter, and you'd have some credit for that. But I had to muster, I'm going to drive myself. I'm going to go myself. And one of the reasons I ended up picking Chestnut Cottage Inn on Hampton Street is when I looked at parking, all of the hotels that were within walking distance, there was no parking. So you're either parking miles away and walking to the hotel, or you're doing valet parking. And all the parking was anywhere from $15 to $30 a day and everything else. So here, the bed and breakfast, they had the parking lot. I don't want to spend too much time there. I'm just watching the timer as this is going. But I ended up staying there because the owners, Ken and Crystal, were so gracious that they allowed me to keep my car there. It took a 15-minute walk. They were 0.6 miles away from the Columbia Museum of Art. So when I left the Friday morning, I got up early, left the bed and breakfast for 7 a.m. I got to the museum at 7. Actually, I think I made it 7:10 because the lights were more forgiving. There's lots of lights and roads, and some of the streets in Columbia, that 4-lane streets within the city. I'm out of phrase. In Kentucky and where I lived in PA, you'd have most of the roads are two lane, one way going, one way coming back. Some may call that one lane because you only got one lane, no passing. And you might have some that's like 2 on each side. So, but here 4 lanes all going this one way, and 4, so you could call that 8 lane, I guess. But oh wow. And so you're crossing that. It's like I'm doing the walks. You're white seated walking. I walk fast, and I'm only halfway through, and then it's blinking red. It's like, oh my! Thankfully, I didn't get hit. But anyway, to the conference. To the conference. To me, I had people after I did my presentation. You drove 7.5 hours here for an hour presentation. Yes. And it was worth the stress. It was worth the anxiety. It was worth pushing through the fear because I didn't know what to expect. Because when I worked in hospice up in PA, we never were given the time. None of the agencies gave us the time to go to events like this. Now, I am sure that if they had the event within the city where the office was located, they would have made a way for us to go for a portion of the conference. But we're out there seeing 6 to 8 patients a day. Sometimes it might be 4 or 5 if we're doing an admission. FYI, a lot of the agencies out there, if they know you're an experienced nurse and you know what you're doing, they may not view it as taking advantage of you, but from a point of view, they are. Oh, you could do an admission plus 4 routine visits, can't you? And most of us, and I do struggle with saying no. I've gotten better at it. Sadly, it can get you pushed out the door. that's what happened with the one agency, because I kept begging. I said, I'm averaging 50 to 60 hours a week. Now keep in mind what an average is. In order to average 60 hours a week, you're going to have some 80s, you're going to have some 40s. And I said to them, I said, I really want to do 32 hours a week. I'm willing to go 40. Oh, that's the equivalent of full time. I said, you don't understand. What you're giving me is pushing me out towards some weeks are 80 hours. I can't do this every single week. And so you say no. But so here to be able to go to this, and I got there. I was looking, I don't have the business card handy. Met one of the vendors there that does body donation. It was wonderful talking to them. I'm almost tempted to go over to my one tool that I use to keep track of for Madison County for resources, because even though they're not in even a Kentucky, they come to Kentucky to pick up bodies for anatomical body donation. And we were going over that one of their first set of I don't know if you want to call them customers, clients, was from Kentucky, because UK Health would sign up people early for body donations, and then when the person died, not necessarily on purpose, but find a reason saying no. That is, no offense, that is awful if that's true, because the family's got their hopes up, and now they're dealing with the grieving process. They just want the body to be taken out, not having a dead body remain there for any real length of time. I'm not saying that applies to everybody. Some people are very comfortable with that and actually want that because they want people to come there for a viewing versus a funeral home to have it more natural. So here to say how that their process is more forgiving, that was very good but I got a chance to meet that. And then I went in, and Dr. Ben Thompson was so gracious. He came, and then Lauren, and I apologize, I don't remember everybody's first names. I know there was a Benjamin Lamb on the conference committee. There was like 3 of them. And Lauren, I apologize. I believe your last name starts with a K, but I apologize. I did not memorize your last name if you're watching this. But they're coming in to set things up, and I asked, Ben, where's the loft? Oh, I'm taking my computer there. Give me a few minutes, because they had several areas where you can go for the different presentations. So they had a theater. I was up in the loft. And then there was a salon, what's called a salon, and it was just amazing. He set everything up. I did not do a count because they don't have a way on this tool here to get a count of the people who went. But last year was 130 people, and based on what I would call a full house, I wouldn't be surprised if the count was 100 to 150 people that were attended. But let me go here. I just want to give you a couple things. One, must have hit the wrong. Okay, speakers. So I was one of the keynote speakers. I spoke from 1:30 to 2:30. Beyond the Flip, advanced hospice prognostic assessment. I'll go over. I really wish they would have put pictures for some of the people. Avery, I'm going from memory. I believe she talked about anticipatory grief. Hers was extremely well done. I was really torn when it came, because some of the sessions were literally you had to pick between a rock and I don't know if it's a rock and a hard place. You had to pick between 2 of your favorite meals. Oh my word. Or your drinks, or two favorite things you love to do. What do I go to? Because here, for example, on the do I have it handy? Give me one. Sorry for the pause. Sorry for the pause. Let me. Oops. So okay, so it wasn't okay. Avery wasn't. Oh, sorry, apologize. Avery was talking about what matters most, how clinicians can invite and support caregivers. And this is extremely important. And Shelley Henry, hi, if you're watching this, I did recommend in my presentation that everybody follows you and AMI Group on LinkedIn, Facebook, Instagram, and TikTok in terms of your videos for hospice and palliative care providers. But Avery did about caregivers, and the reason I brought up Shelley Henry is Shelley Henry, myself, and Avery are like, we have to involve the caregivers in our discussions. We could not forget them. And then it was Megan and her, they have this sorted interestingly. And then it was Megan Lewandowski who did Grief Before Goodbye, anticipatory grief across the lifespan. And that was an amazing presentation. But like they're both being given at the same time. Which one do I go to? And it was like, oh my word. But before I go on, because I'm actually out of order for the presentations. So it started off with welcoming, and then Dr. Abigail Nathanson gave a keynote speech. Now, Abigail was coming, that's her here. Abigail was supposed to fly in from New York, and if you're paying attention to the news with TSA and huge flight delays. By the way, one of the reasons I drove from Berea, Kentucky to Columbia, South Carolina, 7.5 hours, that included trips at the different rest stops. I got maps for all the states going and coming. That was one of the pluses that I treated myself to. Yes, I'm weird. But flights from Lexington to Columbia, starting at $800. She ended up not being able to make it, so she did hers by Zoom. And even by Zoom and technological challenges, she did a wonderful job. So she had talked about operating within the umbrella of your stress. And I'm paraphrasing. This is my way of wording things. So she shared that if you look at 3 levels, the bottom level is you are unbelievably calm. You're unbelievably collected. You're like laid back. And she said, well, that's great for resting. If you're working with your patients, you actually want to be one level up, and that's where you're in this fight or flight mode, but it's more controlled. You're not in a panic mode. You're on fight or flight mode. You're under the umbrella. And that's where you're going to use that as a superpower as you're going from patient to patient to patient. And then there's that panic mode of having a panic attack that above the umbrella that you want to stay out of. And she gave excellent analogies and illustrations on that topic. Dr. Nathanson, did such a wonderful job, given that it was by Zoom and everything else. And it was like, wow. And just give me one moment just to find. I didn't. I downloaded the slides, but like she was going trauma at end of life. She was looking at trauma. Trauma at end of life, mistrust, non-compliance, existential distress, despair, demoralization, just looking at like how are people impacted with trauma versus adversity. This is multifactorial. When I was talking about up under the umbrella, I'm talking about the providers, the clinicians, like people like me, people like you, if you help people in this field. But then she was looking at the patient end, looking at trauma at end of life, trauma versus adversity, just giving pros and cons at each. I have stuff I still have to look up from this. I have to look up AEDP as a palliative framework that was developed by Hilary Jacobs Hendels, and the change triangle. Oh, that's one of the things I need to look up. It's like, wow. And the ending segment for Abigail Nathanson, if I want to give you one tidbit that I got from her that I want to carry forward, and I even though part of me knew this, it got reinforced because I made the time for this conference. You ask every patient, every client, everyone that you care for, that you're going to provide care for, what do I need to know about you to take good care of you? What do I need to know about you? Sorry, looking for a pen, bear with me. What do I need to know about you? What do I need to know? Oh, actually, I do have it written down. I forgot I couldn't see the headlines. What do I need to know about you to take good care of you? That's question one of two. And then I didn't think of this. I wouldn't have thought of this, even though it's logical. So first, what do I need to know about you to take good care of you? Second, what is that like? What does that look like? Wow, that was so powerful that the next presentation, the one that this was another one, Catch 22. I was like, the presenters, we started using what Dr. Nathanson said. Now, I did not use that in my presentation because I was talking more about other areas, advanced prognosis. I was going for the clinician. But when we got to Dr. And I apologize, I believe it's Gunjan. I wow, what an amazing doctor. We're gonna go. Give me a moment here. But 8 to 9, the I'm sorry, 8 to 9 was the first keynote, the opening keynote. Then 9, 10, it was like, oh my word, two great choices: building resilience, and the act to reduce burnout. I did not get to go to that one. This is like, which they both sound wonderful. But here, as a rural hospice and palliative care nurse, I have rarely been at most, on a phrase, almost all my patients have been adults. Shouldn't say all my patients have been adults. So here, Dr. Gunjan, and I'm saying her first name, is it Singh? Challenges for a child in foster care with a terminal illness. Oh my word. She gave, I was like amazed. We actually ended up, we sat down together for breakfast. It was her, it was a Minnie Darby, who's another amazing. She didn't wasn't a presenter, but she sits on an ethics committee for a hospital, mainly in ICU cases. And I don't want to go. I do want to get back to me in a second because this is going to apply to anyone who loves advanced care planning and ethics. But Gunjan, wow, I did not understand the challenges that not only we're not only talking about children receiving pediatric care and pediatric. I'm sorry, palliative care. Palliative care is not hospice. Hospice includes palliative care, but palliative care by itself, you can get a cure, you can get aggressive treatment. You're not looking at a prognosis. You're not even looking at a diagnosis. You're looking at symptom burden. But children in palliative care and or hospice, that's emotional enough. Foster care, I did not realize how little power the foster care parent has, or parents have in the system. They know the child the most. They're with the child every single day in one way, shape, or form, and they have so little say. And so she gave us, the people who attended, a real life, it was her patient that she was involved in, case study. And I was floored. It wasn't until the last few weeks of the child's life where the foster mother was such a compassionate, caring individual that not only was she buying a number of the drugs out of pocket because of the issues that were involved with foster care and everything else, she adopted the young child who was dying. And it wasn't until that adoption was finalized that she was able to change the child from a code status to full code, do everything to keep that dying child alive, even if it was hurting them and making them suffer more, to DNR. Sorry if I get emotional, but I was blind to this. I didn't know about this. I was ignorant of this, but it was so eye-opening and so moving. And before I go over to the next speaker presenter, I mentioned Minnie Darby. And me, if you're watching this, I apologize. I don't know your titles. All I know is I really, really enjoyed our short conversations. We sat at the breakfast table. There were Three of us, some others joined, but they were more on the. I thought I'm introverted, but or maybe they were trying to catch up or play safe. I don't know the words. I apologize for that. But we got into a deep ethics where she works, and I apologize. I believe it's in South Carolina. They were looking at, do they legislate? Do they make it a law that everyone who is an adult is forced by the law to have advanced directives? I am passionate about advanced directives. I strongly believe everyone 18 and older needs to have a set of advanced directives. That's your living will, your durable medical power of attorney. Now, most living will documents will include this. Your durable financial power of attorney. Please don't forget the durable financial power of attorney. Very critical, because that's not included in the living will. And then optional documents for dementia, mental health, VSED, and there are others out there as well. I'm a strong proponent of it. That's part of what I do for a living. I believe I do it, no offense to lawyers, I believe I add more value than lawyers, because I developed a 16-page value worksheet that works through the values and 10 value-based decision aids that works over key points. And by the way, me and I were in agreement that on the POLST, which is a physician's order for life-sustaining treatment, Kentucky uses the MOST, medical orders scope of treatment. And some states use MOLST, same thing as POLST, but it's medical orders for life-sustaining treatment. That Section B, medical interventions, can override the living will. All that hard work that you did, if you don't fill in Section B correctly, you can cause problems. And I help people avoid that. That's what makes me different from a lawyer, because a lawyer doesn't even know about, most of the time, don't know about the POLST, MOST. But me and I were going over how we were both against legislating living wills. So her standpoint was, if you legislate it and you get this done at the age of 18, what happens when you're 20, 30, as you go through life changes, your desires, like when I was in my 20s, I would have been full coke. I didn't know any better. And by the way, when I talked to other nurses at this conference and social workers, a lot of them were like, isn't it interesting that the moment you get into healthcare and you work any length of time in healthcare, you want to be DNR? Isn't that interesting? Isn't that interesting that most healthcare workers, I'm not saying all, I've not done any statistics, but at this conference, most healthcare workers, the moment you start healthcare, working in healthcare, you want to be DNR. Wow, we know something that the public doesn't know. And that is that full code isn't what it's made out to be. CPR is not what it's made out to be. And by the way, rabbit trail, I strongly, it won't happen in my lifetime. I'm going to be 63 in May, but here, why on earth do healthcare professionals have to have CPR certification? If the success rate sucks, literally, in the hospital setting, 20% success rate. So out of every 1,000 people, 800 die. 800 die out of every 1,000. In the community, you're walking down the street and you do CPR, 1% live. So out of the same 1,000 people, 999 die. Nursing homes, 5% live. Same 1,000 people, 995 die. Why should we be forced to get certified with that dismal failure rate? I don't, and I'm not saying, I don't know how to word things. I struggle sometimes, but Peter, if you could save that one life. Well, don't make it a force thing. This is part of my frustration. You know, healthcare providers, you have the card. You're forced in this. In some areas, you can make a clinical decision that it's frailty, but then you now have to fight to prove, versus getting, losing your license and other things. Anyway, before I go too far down the rabbit trail, I loved their conversation. But then getting down into the other presentations after that, Dr. Gunjan's presentation, I had an opportunity to, I went outside to eat lunch because in the museum it was very cold. Not too cold, but it was like cold enough. So I wanted to get some sun, and she joined me, and then Dr. Ben joined us. And that was one. This is a connection. She gave me her personal cell phone number. Wow, I don't know if I'll ever need it, but now I have a resource for somebody who is both a pediatrician and a palliative care pediatric doctor. I have that contact because we have that connection. Same with Dr. Ben Thompson. And Dr. Ben Thompson said one of the ways that people get employed, especially in more elevated positions, is they go to conferences and they meet people, and especially if they're speaking, no matter whether it was a keynote or a regular presentation. And so here, next we had, oh my word, this was hard. They had palliative care beyond the agenda. The program coordinator is a core member of the disciplinary team. Now, many agencies, both palliative care and hospice care, have a program coordinator. I did. I was like torn. Do I go to that one, or do I go to holding autonomy together, and interprofessional palliative care, cross culture and trust? That one was done by Dr. Andrew Tyson, and I am not Tanizid Dominguez. I ended up going to that one because I love helping people that are culturally different than me. I love helping people that are culturally different than me. In my hospice journey, I have provided care for undocumented individuals on several occasions. So they were given an example of a gentleman from Guatemala, and they did such a wonderful job. In fact, everyone here, and I know I did not get to go to the ending. I think there were two more podium presentations before the final presentation of the day. I didn't make those, but this was so well done. This was so well done. But the two of them, and they played off so well. They took turns speaking, and their presentations. This is the I did not put it in my commentary, but this is one where actually they had three presentations in a row. Each one was 15 minutes, so combined 45 minutes. I really, if I would have made any change, it really should have been 2 versus 3. To have them have more time speaking, but wow. So even though I've cared for the undocumented, and they were talking about an documented case, they were going over the challenges. Like the Guatemalan gentleman, when it came time for medications, this person did not qualify. They were not on any insurance. No Medicaid, no Medicare, no insurance. No insurance. They were working here in the United States of America, but they did not have insurance. So here, when they got their prescriptions, this is for your pain medication. They were on hydromorphine, Dilaudid. It's for your pain medications. This is for your nausea. This is for this. They actually had to pick and choose what they can get filled. Can you imagine that? Do I get the pain medication so I'm in less pain, but then I'm throwing up all over the place, and that's not comfortable? Or do I get that so I'm not throwing up but then I'm in more pain? Or this symptom or that symptom. The social I forget whether it's Miss or Mrs. I apologize. I have trouble pronouncing the first name, but Mrs. Dominguez or Miss. She, connecting with Good RX just to try to help, and then here, because of language barriers, and both her and Andrew, uh, handsome guy. I actually I admire. So I go back here to the. I am weird. I can look at men and this person's handsome, and women this is beautiful, and yes, I'm heterosexual, not bi, but it's like and I know that's weird to say. I am weird to begin with. Just like to clarify things, like I tell people I love them. It's platonic, like brotherly, sisterly. Anyway, but they were like, they're bilingual, but even with bilingual, they were running into language difficulties. And they were sharing one of the lessons that they learned, I'm going to pass on to you what I learned from them is they went in, and I'm paraphrasing, but using some of their wording, they went in with their own agenda. Their own agenda was to manage the symptoms. That makes common sense, right? They wanted to get advanced directives because he didn't have any. He was full code until towards the very end. So they wanted to get advanced directives done. They wanted to manage the symptoms, and they wanted to try to see, was he going to go stay here in the States and die in the States, or was he going to go back to Guatemala? By the way, the reparation, going back to your country of origin, is common. It's difficult. I didn't know how difficult until they went through their presentation, because there were consulate issues and so forth, and it's consulate on the other countries like Guatemala side. But wow. And what they found out is the best role for palliative care and hospice providers working with undocumented, as well as, keep this in mind, this doesn't have to be an undocumented person. This could be a person of any culture that's not your own, or could be your own, is we are there to be supportive. It's not wrong to have an agenda, but we are there to support their journey. Now, that may be common sense, but sometimes we need reminders of that. We're there to support their journey. So they became the sounding boards for this gentleman who they were getting frustrated. He had a feeding tube. He actually they did NG tube for gastric suction and so on and so forth, and then feeding tube and other issues. And it was like they were there to just try to be a sounding board. And these are the pros and the cons of your decisions. And then and they were going through so much. I'm trying to remember. Okay, the gentleman had a Whipple at the beginning. He was trying to do natural. Had a Whipple, then was having severe abdominal pain, and then he blamed the Whipple procedure versus the cancer's getting worse. And they learned they just needed to be the sounding board for that person and try to guide them, but it's all on their journey. And they did an amazing job. And I was so grateful because all except for Dr. Nathanson, who did not make it, all the keynote speakers and the podium presenters, they came to my keynote. And when I would look out at the audience, they were smiling. And that really helped me. If you're watching this and you're one of the speakers, thank you. You helped me remain calm while I was giving my presentation. Your beautiful smile, your head nodding, thank you. But I went there. Then there was supporting for providers in serious illness care. I did not go to that one. I ended up switching. This is where I'm like running from one end of the museum to the other, thankfully on the same floor. But I went over to, they had support your providers in serious illness care, resident impressions for a lot of medical terminology. It was looking at helping the resident, which is important. But then I ran over to the salon from the theater. What's the goal? The essential role in palliative and case management in enhancing patient care transitions, looking at going through the transitions of care. And for me, looking at the continuity of care, keeping everybody in line, how are we communicating with one another is so critically important. So Rita Sheely and Levi did such a wonderful job for that presentation. And then I'm the geeky nerd. I'm the geeky nerd. So here, for me, the last one, even though these were both technical topics, in the theater, they had transesophageal gastrostomy tubes, a unique challenge in hospice care. Even though that was my type of thing, because I experienced what I'm about to say in the past, and I had questions, I went to Dr. Borelli's, um, that's here, Carly's, opioid-induced neurotoxicity. And she did a wonderful job. Each of these ones that I'm talking about, they only had 15 minutes to give their presentation. I thought an hour was not enough time for mine. But like, oh my word. Because my question was, I have had cases. She was presenting a case where the person was having increased uh, Dilaudid up, or it might have been morphine, but increased up, and then started having having myoclonus, the jerky motions. I don't know if I'm mimicking it correctly, but jerky motions, allodynia, if I'm pronouncing that correctly, which means that the no matter how much pain medication you're giving, how frequently, nothing's touching the pain. Nothing's touching the pain. And I don't have all the symptomology. I downloaded all the slides. I still have to re-review. I'm the geeky nerd. The presentations, and maybe I'll do a video walking you through, keeping in mind I'm not the presenter, so I'm not going to do it as well as a job as they would do, but I could walk you through the slides, and maybe they'll have speaker notes in there so that I could add some value other than just seeing the slides themselves. But it was like, wow. And then she gave ideas of like using opioid rotation. Opioid rotation doesn't happen as much as it should in hospice. It happens more in palliative care, because keeping in mind, palliative care, you don't need to be terminal. You can get aggressive treatment. You can be on palliative care for decades. So you have time to convince the patient it's necessary to switch from one medication to another. Where in hospice care, especially if they're going fast, it can get very hard to convince whoever's making the decision it would be in best interest if we started a new pain medication, even though we might have to fiddle with it, titrate it, make changes to it in order for it to become effective. But I had a question for Dr. Borelli, because I've had cases where we only started them on liquid morphine. We did not increase the dose, and towards the last 1 to 5 days of life, 5 days might be pushing it, they're having twitching, not heavy. Usually like their hands are, and I'm not laying down flat, but their hands or maybe their fingers might be twitching, and that's myoclonus as well. And I would be like, if that's all you have, if all you have is myoclonus and then you introduce lorazepam and it goes away, because one of the treatments for myoclonus as well as opioid-induced toxicity is a benzodiazepine. I said, because, a rural hospice, we're not running tests. We're not in a hospital setting to run lab work, because she did give lab work that you could do to kind of identify and narrow things down. And she said that one, she did agree. That's hard to know. Maybe it is, maybe it isn't. Try an opioid rotation. So then we're coming to a close. But then in the theater, talking about what matters most, I mentioned this earlier, supporting the caregivers. I started that one because I was like, gee, I wrote a book I wrote 2 books on grief. I've taken grief courses. Um, do I need to go through anticipatory grief across a lifespan? And I was even asking Dr. Ben, who do I go to? And he was like, well, I could either toss a coin, go to the one who's least attended, which happened to, sadly, happened to be Avery's one was the least attended, because when I ran over to the salon, I had trouble finding a seat. But I love supporting the caregivers, and I was attending that, and she was doing a very good job. But after I got the gist of it, I thought again, let me go back to the salon. And I went back, and it was like, this is kind of hard. Should I have started there and stayed there? Because the Megan, who was giving that presentation, did such a wonderful job. I don't know if Megan has not too many people have their Megan, not too many people have their picture up. But she was actually looking at what behaviors and symptoms of anticipatory grief broken down by different age groups. So hers is one that I definitely want to go back to her presentation. I have if it was updated in the documents here, most people put their slides. I don't know if they have her slides. Okay, she does. Yay. So I did download all of these slides, and again, I might do a video in the near future for. I'm not going to do all the presentations. It's going to be a several-hour video, but I might do several videos. It might be. Let me just pick one and then go over it with you. Please comment below if you'd like something like that. But it was like, wow. So from this age group to this age group, this is what you would see. So extremely, extremely well done. And then I got to give my presentation, and I was so grateful. So here, to me, this was unbelievably valuable. I it was so valuable. I did put a maybe for next year. I said if I'm invited, I will be a definite. But I don't know. I don't know if it'll be a positive only because of the 7.5 hour drive, but I might. This was, I met people that I would not have met otherwise. I learned about topics that I would have, and I didn't count these. I wish they would have had a way for counting, but this is, I met a number of these people. I had a chance. Uh, Marcette, oh, I love you. Not that I don't love the people I'm not mentioning, but like when I mentioned, I asked the question when people are sleeping, 18, 20 hours or more, what are they not doing? She was the first one. They're not eating. Woo! I know, I get excited. And then we were talking about afterwards about how so many people don't think about that when they're out in the field. And I apologize. There's so many people that came up to me afterwards that thanked me, and we had a chance to talk some more. I'm looking to see if I recognize some of the names, because there was a social worker that came up. Was it Tamika? Sorry. Okay. I'm not recognizing, at least not, I don't want to take too much more of your time as we're going. But I had, yeah, I think it was Keisha Graham, maybe. Just double checking. I believe it was her. Somebody came up to me and told me about the story of their grandmother. And while her story was, to me, everybody should have advanced directives because her grandmother didn't. Her grandmother, when she was in sound-minded body, never wants a feeding tube. Her grandmother said feeding tubes, they should call it forced feeding tubes. Forced feeding tubes. And she was telling me a story that when her grandmother had dementia, how many providers will say, you should now get a feeding tube. Oh, I do want to end. We're on the landing zone. We're on the landing zone. Where I do want to end with, and they did have gamification, by the way. I did not participate. I got 0. But they had gamifications. They had different discussions, including art, new connections, and so on. It was unbelievably well done. I could not have been more grateful for this opportunity. But getting back to the forced feeding tube point of view, are you aware that you can aspirate with a feeding tube? You can get aspiration pneumonia with a feeding tube. There's no science for how much food to force down the tube, because we are forcing it down the tube. If they cannot eat naturally, there's no science for how much volume to put in the tube. Whether the tube is, here, or the tube is in your nose, there's no science to say this is how much volume of fluid, calories, etc. to give. And our bodies are, I still remember my anatomy professor from Harrisburg Area Community College, where she would say the human body is like a hot dog on a stick, where the GI system is the stick. Esophagus to the stomach, it becomes different shapes. To the colon, to the is it rectum, anus rectum? But yeah, and here I call myself a nurse. I am a nurse, but I shouldn't I have this memorized? But I'll get in. I'm not a colon nurse, but anyway, endoscopy. But here, what goes in has to come out, and if it can't come out, the back end, our normal method of pooping, fecal, it's going to come up, vomit. You can aspirate on a feeding tube. And why are providers out there saying, "Oh, you're a danger for aspiration because you have dysphagia"? Let's give you a tube. Excuse me, you could still aspirate on that feeding tube. We really should have discussions that's its own rabbit trail. Either A, you don't, are you educated enough? No offense, are you educated enough? Or are you just doing this because you want to deal with their fear that they're going to starve to death, which is false, because our body is beautifully and wonderfully made. Turn off the drive to eat and drink the closer we are to death. Starvation is a feeling we don't have. So to me, in ending, in terms of covering the points, you get an opportunity to go to conferences, whether it's the South Carolina Hospice and Palliative Care Conference or other venues. Take these opportunities. Yes, it's a financial investment. I'm thankful I didn't have to pay. I got to go to this for free. They made arrangements. I literally, I believe I'm going to get a 𝐂𝐄𝐒 sticker stripping. We agreed on a mileage rate because they were originally going to pay for the flights. I actually saved them money by driving. But because flights, again, Lexington to Columbia is starts at $800. So the mileage was 500 and change for the miles. It was 396 miles one way. So what's that? 792 miles. If I did my math right, 396 times 2, 792. Wow, I'm good at basic math. Autistic plus. So 792 miles round trip. And so that plus the bed and breakfast and the overnight in Hendersonville as part. But even if you're not a speaker and you get to go, yeah, you have your travel expenses. You have your travel expenses. And you might have to juggle as to where do you stay. But if you have the chance, you're making connections. You're making connections. You're learning. Be a lifelong learner. And you're connecting with people that even if they won't be your client, maybe they won't be a direct referral source. I was handing out my business cards every chance I had to different people. We don't know who they're going to be connected to, that they're going to say, "I have somebody that can help you. I have somebody that can help you. Here's the person." Final point. I still remember when I worked in IT and AL leasing. I still remember writing a goodbye email where I shared that in life, if we look at it, when we throw a rock into a lake or a stream, we are changing that lake or stream one rock at a time. And that's the same way with people. When we touch somebody, and it may not be a physical touch, and we interact, and we're smiling, and we're sharing, and we're collaborating, and we're trying to encourage, and we're trying to uplift, we are making this world better. We're making a difference. And in one way, shape, or form, and I don't believe in karma in the literal sense, but in one way, shape, or form, we're changing the world for the better. We're making an impact that in one way, shape, or form will come back to us and will be a blessing unto us. I thank you for your time. Feel free to ask questions in the comments below. Thank you and bye.